Hello my friends, welcome back to my new video in my channel and thank you for your encouraging comments and this is a Diwali time and I wish you all a very happy, prosperous and healthy Diwali. Uh, there was request from one of my very close near and dear friend as to when I will appear in front of you all live delivering the lecture. I will definitely come, but my friend, you'll have to wait for that a bit. And today you will have to excuse me as you could actually listen to the crackers sound on the background. But I think no one will mind it today because it's a Diwali time. So let us enjoy. Uh, so today's lecture is on pulmonary renal syndrome. This is not very common, but not very uncommon either. And this is a talk which I delivered during the annual Critical Care Congress held in Ahmedabad in the year 2022. So, without further ado, let us start with the talk today. So, I think it is important to remember that there is always a kind of relation between these two important organs in the body, that is the lungs and of course the kidneys. So there is definite cross talks which are going on in these two important organs and the vital organs, and let us see how it gets unfold when we discuss the topic. And of course there is interesting case also which I am going to present. So, pulmonary renal syndrome typically presents with acute respiratory failure, either due to a pneumonia, and the kidney manifestation is mainly as a renal failure, the acute glomerulonephritis with focal segmental necrotizing glomerulonephritis on histopathology. There could be ANCA associated vasculitis and of course the anti-GBM disease, and there could be a combination of these two, as you could see later. 75% of PRS can be in ICU, and they would need ICU in some point of time during the course of their illness, and rarely it can be with SLE or cryoglobulinemias, drugs like hydralazine, allopurinol or propylthiouracil. So as I said that there could be association of ANC associated vasculitis with anti-GBM disease. Now, as far as the pulmonary symptomatology is concerned, this is predominantly due to diffuse alveolar hemorrhages, and these patients present classically with hemoptysis, bilateral alveolar shadows, as you could see here on a CT scan, and anemia. So, this is a triad and a very classical triad of the pulmonary symptoms. As far as the renal symptoms are concerned, they can actually present with rapidly progressive renal failure, the RBC casts on urine routine, and of course hematuria. So the RPGN, which is due to the damage of capillaries and the basal membrane with leakage of erythrocytes, and there is also influx of macrophages and fibrinogen with extracapillary cell proliferation giving rise to what is called as the crescents, and this is a very classical terminology which is associated with RPGN. As far as pathophysiology of this PRS is concerned, one third of the patients can have actually a ANC associated vasculitis. There can be a immune complex associated vasculitis and a posse immune vasculitis, as you could see, and of course there is anti-GBM antibody. So this is a very classical kind of pathophysiology associated with PRS. Classical pulmonary capillaritis, which is evident in this uh, histopathology slide, and this is a entire spectrum of the pulmonary renal syndrome. So if I can see here, you it is a good pasture syndrome. So you have a pulmonary renal syndrome associated with anti-GBM antibodies. The ANCA positive systemic vasculitis, predominantly the vaginous granulomatosis and microscopic polyangiitis. The pulmonary renal syndrome in ANCA negative systemic vasculitis like henox-conlin purpura or mixed cryoglobulinemias. ANCA positive PRS without systemic vasculitis. So here we have idiopathic PRS or posse-immune necrotic glomerulonephritis. So this could be ANCA positive. PRS in drug associated ANCA positive vasculitis, predominantly propylthiouracil, hydralazine, allopurinol. PRS in anti-GBM positive and ANCA positive patients. PRS in autoimmune rheumatic diseases. Here you have SLEs and polymyositis and rheumatoid arthritis and so on and so forth. PRS in thrombotic microangiopathy, so predominantly it could be TTP, and of course diffuse alveolar hemorrhage complicating idiopathic posse-immune glomerulonephritis. So this is an entire spectrum of PRS, and we will come to that in a short while from now. So as you could see, this is the distribution of various pathologies. As you could see, PNCA associated vasculitis is, can be seen to the tune of about 40%. CNCA, so this is a PNCA vasculitis, this is CNCA vasculitis is around 27.5%. The PNCA with anti-GBM about 14%, anti-GBM disease about 3.8%, and others about maybe 25%. So this is a distribution of various pathological entities. So diagnosis of course starts with a proper history and a detailed clinical examination, which has to be done in almost all the cases. The lab parameters, the urine routine. Of course, we may go ahead and do a bronchoscopy with BAL studies, and in few cases the video assisted thoracoscopic biopsies of the lung or the lung lesions, as you could see in this particular cartoon, and of course the renal biopsy. So this is an entire array of the diagnostic approach for the patients of PRS. As far as lung biopsy is concerned, they can be examined on the HE stain and also the Orsin stain with immunofluorescence. So there could be linear IgG immune deposition within the alveolar basement membrane, which is highly suggestive of good pasture syndrome. When we see a irregular granular immunoglobulin staining is suggestive of SLE, and if there are no immune deposits, then it is highly suggestive of ANCA associated vasculitis. So this is a very important kind of a signal where we could actually suspect one particular diagnosis based on the lung biopsy report. So here could be a flow chart for the diagnosis of pulmonary renal syndrome. We have an impaired kidney function plus respiratory failure. You see a urinary sediment, and of course if it is kind of inactive, it is ICU associated AKI. If it is active urinary sediment which is seen, you should suspect glomerulonephritis. And at the same time, if you have a respiratory failure of unexplained origin with hemoptysis and pulmonary infiltrates, then of course the diagnosis of PRS is almost certain. The conditions which are excluded would be obviously sepsis, aspirations, P's, and fluid overload. And of course, when you have a PRS, think about kidney biopsy and of course serology, and we'll come to the serology in a short while from now. So classically, vaginous granulomatosis is a CANCA positive disease where you have the ENT manifestations, lung manifestations, and kidney manifestations. So, classically, when I was a postgraduate student, it was classically taught to us that ELK manifestations of vaginals, that is E for ENT, L for lungs, and K for kidneys. So as you could see, the target antigen here is proteinase 3, that is PR3. So if you have a PR3 CNCA, most likely it is vaginous. Coming to microscopic polyangiitis, there are no ENT manifestations here, but of course there is a diffuse alveolar hemorrhage with glomerulonephritis, and it is a p-ANCA positive vasculitis with myeloperoxidase as the target antigen. So if there is a MPO, p-ANCA, think about microscopic polyangiitis. If it is PR3, C-ANCA, think about vaginous granulomatosis. As far as good pasture syndrome is concerned, there are no ENT manifestations. There is a diffuse alveolar hemorrhage with glomerulonephritis, and of course there is anti-GBM or ABMA serology which is positive. So this is actually in short. So this is anti-basement membrane antibodies which are seen with good pasture syndrome. So this is in a nutshell and in a very easy to remember slide where you can have a clinical pointer based on the laboratory parameters as to which particular entity of PRS you are encountering in that particular patient. So I was talking about the serology, that is ANCA, and again these are various conditions in which the ANCAs can be seen positive, but these are all the other antibody assay which we could do, like ANA, the anti-Rho, La, anti-Smith, anti-DNA, cryoglobulins. These are all antibodies, and of course, as you could see here, the anti-neutrophil cytoplasmic antibody, that is ANCA, the MPO, and the PR3. These are the target antigen which we just saw, and of course the anti-glomerular basal membrane, which is good pasture. So these are the three conditions which we discussed. So if it is a PR3 and C-ANCA, it will be vaginous. If it is MPO and P-ANCA positive, it will be microscopic polyangiitis, and if it is anti-glomerular basement membrane positive, then it will be a good pasture syndrome. As far as prognosis is concerned, the mortality, if it is not treated, can be to the tune of 25 to 50%. And the older the age, higher the creatinine on presentation carries poor prognosis. Along with, if the patient has a severe kidney and a lung disease or severe upper airway disease, and the anti-PR3 antibody is positive, it carries a poor prognosis. ANCA negative, which has a poor renal outcome than the ANCA positive patient. So this is one of the findings which we should remember. And disease relapses, there could be drug toxicity and infections which can worsen the situation further. As far as treatment is concerned, we are talking about ANCA associated PRS. Of course, methylprednisolone in the dose of 500 to 1 gram IV for 3 to 5 days. We can also consider prednisolone 1 milligram per kg for 1 month, and it can be tapered over next 3 to 4 months. It can be actually potentiated with cyclophosphamide in a dose of 0.5 to 1 gram IV month as a pulse therapy, or orally it could be 1 to 2 milligram per kg per day. And of course, plasmapheresis, which can form a mainstay of the treatment, especially for ANCA associated PRS, at least for a week. In critical ill patients, there can be considerations in the form of ECMO or activated factor 7, and after remission they can be on oral low dose steroids with cytotoxic agents. So here I think someone should not forget the steroids, the type of steroid and the dose of steroids. The plasmapheresis, of course, has to be as a mainstay of the treatment. As far as good pasture syndrome is concerned, plasmapheresis again is the treatment of choice for about 14 cycles. For SLE, there is consideration of cyclophosphamide and in few cases rituximab and mycophenolate as immunosuppressant. Acute catastrophic antiphospholipid syndrome, we need to consider a very aggressive anticoagulation therapy. And for TTP, again the classical uh, plasmapheresis or plasma transfusions awaiting plasmapheresis. There could be a consideration of kidney transplant in about 66% of the patients in the course of the illness for about 4 years. So kidney transplant also needs to be remembered. So last couple of slides on our own case in my ICU, which was kind of a atypical case, as we could, if you remember, we discussed posse-immune crescentic glomerulonephritis is usually associated with ANCA positive, and here I am presenting a case which was ANCA negative, which is seen in only 10% of the patients. So this was quite a atypical case, and these are the references to support my statement. So this was a 26 years old female patient. This was in August 2021. She had hypertension, CKD, and the BP when she came was 240 by 120, with saturation on room air was just 66%. Obviously, she had extreme respiratory distress, tachypnea, tachycardia, hemoptysis. Again, as I said, this forms a very important triad of the symptoms for PRS as far as pulmonary manifestations are concerned. She was put on piperacillin tazobactam with amikacin and meropenem. Uh, so obviously she required ICU, and we started her on NIV. She was hemodialyzed, and she got settled a bit. But she had a history of posse-immune crescentic glomerulonephritis on biopsy way back in July 2021. So we gave her pulse steroids and pulse cyclophosphamide. We started her on with plasmapheresis. The 3 cycles were given. She also had a history of COVID in December 2021, and of course, plasmapheresis, we had 2 cycles. So here we are discussing this case in 2022, and that is why I'm saying that she had a history of COVID, because this was in 2021. She underwent a kidney transplant in February 2022 with ABO incompatible, and the father-in-law was the donor, and the last creatinine was just 0.8 milligram per deciliter. And this was the X-ray, which is classically you could see bilateral, diffuse, heterogeneous, alveolar air space consolidation. You could see that the HD catheter is in situ. So this is the lab profile, and as you could see that the P ANCA and C ANCA were negative. The MPO ANCA and the PR3, the target antigens, were negative, and of course the glomerular basement membrane antibody was also negative. So this is the first step for the laboratory investigations when you come across a patient with a suspected PRS, that you go ahead and do a ANCA. Then of course the MPO and the PR3 antigens, and of course the glomerular basement membrane antibody. The kidney biopsy, which showed the features of posse-immune crescentic glomerulonephritis with associated tubular injury and interstitial inflammation. This was the X-ray which I showed. This was a CT scan with a very florid kind of pulmonary airspace consolidations, bilateral, diffuse, and you could see the air bronchograms in between. And after the plasmapheresis and the immunosuppressive therapy, you could see that there is a gradual clearance, and this CT actually shows that the patient actually improved almost 90% of what she had, and even clinically she was much better. So, my friends, this is my last slide, and this is the suggested reading for this particular topic. As I said, this is not very common, but this is not very uncommon also. So, I would actually urge you to remember few of the points which we discussed in this particular lecture. The triad of pulmonary symptoms, the triad of the renal symptoms, and the, the different pathological, serological tests which is done, and of course the therapy in the form of the immunosuppressants, the steroids, and of course plasmapheresis. So that's all for today. I hope you have enjoyed, and I'll come with the next video with an interesting topic. And take care, enjoy your Diwali, and we'll meet you soon. Bye bye.